Today we're going to be starting on lower back pain. I'm going to run through some common presentations and the way that we assess and treat in physio. I'm also going to give you guys an idea of different types of exercises that you can give to the patients so that they can start to implement to start reducing their pain. I know it's often a challenge to get the patient to be compliant with that, so hopefully with a little bit more information you can educate these patients on what are some common exercises and what they need to do to relieve their pain. I hope you get a lot out of it, and if there's any issues, just let me know at the clinic. Thank you. So the first video that we're going to be giving on education is a lower back video, and we're going to do the classic spondylosis or facet joint problems. Okay, so Michael, my other physio, is in this case a 50-year-old gentleman who is a bricklayer and has been working harder to reach a deadline to build a house. And so he's presented to your clinic and is complaining of pain in his lumbar spine, probably a diffuse type pain across his lower back, okay, and pain with activities like flexion, prolonged sitting, maybe restricted movement, lateral flexion side to side. So basically he's got restricted movements. So the first thing we need to do is assess those movements. So a really quick test is Michael's going to reach to touch his toes. He'll often have restriction about mid-shin, about that level. Okay, he'll complain of pain across his back, not a very sharp pain, just a tightness. That's a common thing that'll be said. He's then going to come up, put his hands on his hips, lean back into extension. Similarly, there'll be restricted movement into extension. Then he'll come back to the middle. He will go into lateral flexion, down to one side. Often one side will be more restricted to the other side, and he'll stop about midway down, complain of pain and restriction. That's the best way that you can assess as to how this patient's back is moving, if it's moving properly. We're then going to do two quick special tests to determine if there's any neural or nerve involvement. First one is an S1 calf raise. Patient's going to place his hands on your hands. He's going to stand on one foot and try to go up onto his toes 5 times. Often there'll be imbalances. This is a quick special test that you can determine if there's any calf weakness which would be associated with an S1 nerve root compression. Okay, the next one we're going to do is do a single leg stance. Okay, so Michael's going to bring his knee up to the 90 degree. What you'll often see is that they have an imbalance or a pelvic drop to one side. So I'll get Michael to face the camera. Often when he lifts up to one side, we'll have an ipsilateral, same-sided pelvic drop. That's associated with sacroiliac joint dysfunction. Okay, we'll now progress onto the bed where Michael will lay on his back to perform reflex, straight leg and a few other neural tests. First things first is that we're going to perform a straight leg raise. I'll ask the patient to relax completely. We'll lift the leg up. There will be some resistance at approximately 45 degrees. We'll then drop the tension off, apply a dorsiflexion strain that will reproduce some tightness in the hamstrings. We'll then do the same on the opposite leg where we lift it up. There may be more range of movement. Again, take the tension off, apply a dorsiflexion overpressure. If that's clear, then we know that the affected limb has more neural tension, which will be associated with pins and needles, numbness, any other of those ridiculous signs. We're then going to use a reflex hammer to work out the L3 reflex at the patella tendon. You'll hit it. There'll be no reflex, or move down to the S1 reflex and we'll have a slight dorsiflexion reflex. Same on the other side. I do a quick myotomal test. So we're going to take the knee up to hip flexion, ask the patient to hold that and resist L2, go into knee extension, resist, good, come down into resisted plantar flexion, into dorsiflexion, and then into eversion going out. Okay, we can then take the patient's shoes off and do L5 big toe extension. All right, now most importantly for any type of facet joint injuries is we really want to be looking at their actual facet joints and mobilizing their facet joints. So we're going to ask the patient to go onto their stomach. okay? Head in the head hole, expose their lumbar spine, okay, down to the level of the sacrum. Now, often with this patient, you'll see that there's an increase in muscle spasm in the thoracic spine. This is a really important thing that you can start to do with your patients to ascertain as to whether the patient will respond to physiotherapy. A good physiotherapist will use his hands to assess the facet joints in the lower back. What I always like to do is, if Michael was sore on his right side, assess the left side first. So we're going to start about mid-thoracic if we're treating the lumbar spine. We're going to find the bottom rib, T12. We're going to follow it up, and that's our marker that I'd like to start at, okay? We're going to do some central mobilization first, moving down, applying a PA pressure where your thumbs are together, moving through L1 all the way down to L5. You're then going to go to the unaffected side, starting at your T12, moving the paraspinals out of the way, mobilizing in a PA direction, probably at about 50% of your maximum force, moving down to L1, all the way down. Often the patient will report that this is the painful segment. Mobilize below, mobilize above, to get an idea. I do exactly the same thing on the other side, okay? So L1 down, L2, L3, L4, L5. I also like to do what's called a pisiform grip, so hands together, make a C, and then mobilizing the sacroiliac joint. Again, I'm not pressing extremely hard, we're just gently mobilizing, and that should be enough to reproduce the symptoms. This is really important to determine, as I said before, if the patient's going to respond to manual therapy. The joints will stiffen up due to activities of daily living. When my hands come in and mobilize those joints, or your hands come in and mobilize those joints, what you are doing is you're reintroducing movement to the stiff facet joints, okay? If you can get the facet joints moving, the patient will then hop up off the bed. After about 5 minutes worth of mobilization, if we, or say 3 minutes even, if we reassess the patient's movements, you'll find that they instantly can move more, both into flexion, extension, and lateral flexion, okay? It'll make a big difference immediately, okay? You may have to do 2 or 3 sets of this mobilization to get an outcome.